So when we're considering a PCI strategy to the left main, we need to remember a number of factors. Firstly, the left main is a big vessel which supplies an awful lot of myocardium. Secondly, it will inevitably involve at least a bifurcation, if not a trifurcation. Thirdly, it's very common for there to be calcification of the vessel, which is going to make it difficult to expand our stents. Fourthly, the hemodynamic consequences of loss of a vessel, so loss of a side branch, will be very much greater in the left main, where that side branch might either be the LAD or the circumflex, than it would be if we were treating a circumflex bifurcation. So all of those things combine to make left main intervention a challenge which needs planning and needs stringency with regard to making sure that we get the optimal angiographic and procedural result. So when we're treating the left main, there is inevitable interaction between the guide catheter and the coronary artery, which is again unique to the left main. So that guide catheter interaction with the main is going to be something we need to take into consideration. It's going to impact on how we assess the true ostium of the main. And it also means, because of the angulation, it can be very difficult to get clear information about the true stenosis of the ostium of the individual branches. So as a consequence, intravascular ultrasound, which gives us in-vessel information about not only the diameters but also the character of the wall, is a very good way of planning our procedure to make sure that we perform the procedure optimally. So in the last year, we've got data from two big randomized trials. The Excel trial, which is about 1,800 patients, the Noble trial, which is about 1,200 patients, where we compared head-to-head bypass surgery versus stenting in patients with left main disease. The major thing that comes out of that for me is that there was no mortality benefit from cardiac surgery in either of those trials. And certainly if you combine the data, it's very clear that an interventional strategy with stents is a safe strategy. I think it's likely when we get drill down on that data that there may well be subsets of patients where angioplasty and stenting has a definite advantage over surgery, and I anticipate that would be ostial disease and perhaps shaft disease. Bifurcation disease is always going to be more challenging for the interventionist to treat, but what we see really when we combine the data is that surgery continues to perhaps provide a more durable result, with angioplasty likely to require further procedures over time, but ultimately we've seen a very safe procedure, and we're guaranteeing a very safe outcome for our patients if we decide stents. So how I put these things together broadly is that actually I'm not sure there's that many patients where there's equipoise. I personally feel that for most patients, if you look carefully at the anatomy, carefully at the patient, that one of the major revascularization therapies will appear to be likely to be the beneficial one for this particular patient. And if we discuss that with our patient, that would usually be our recommendation. And that's how we do it in Oxford. We take the patient data, we take the angiographic data, we combine it in an MDT discussion and try and work out what would be best for that individual patient. So intravascular ultrasound, I think, is a really useful tool when we're thinking about treating the left main. It can help you at the beginning of your procedure, help you plan it. It can help you during your procedure, and it can help you at the end to be absolutely sure you've got a fantastic result. So at the beginning of the procedure, I would use it to ensure that I need to treat the left main itself, and also particularly to be sure about the bifurcation. Is there disease in both branches of the bifurcation? Is this a single stent strategy or a double stent strategy? And I make that decision by IVUSing the less diseased vessel on the angiogram with IVUS. So that if the circumflex does not appear to be significantly stenosed, if I do IVUS, if I've got an MLA in the circumflex of less than 4, this is going to be a 2-stent strategy. It tells me whether I need to do rotablation. It tells me whether I can do predilatation with balloons. During the case, the intravascular ultrasound is going to help me size the stent. I'm going to size to the reference vessel distal, and then I'm going to pot the vessel proximally to make sure that my stent is optimized with regard to its expansion within the left main body. And then at the end, particularly if I've done a 2-stent procedure, I want to be absolutely sure that I've fulfilled the target criteria of Kang with regard to the lumen areas that I've achieved in my 2 stents. So 5, 6, 7, 8, circumflex, LAD, confluence, and left main body respectively. And really that information is just not achievable with angiography alone. We can only get that sort of information from intravascular ultrasound. And of course, if you look at the trials, certainly within the Excel trial, nearly 70% of cases were guided by intravascular ultrasound. And so that's a very important message for us as we go forward, that scrupulous technique is essential if we're going to match cardiac surgery with regard to long-term outcomes. So there are two big registries, both of which suggest a potential mortality benefit from using intravascular ultrasound. There's a Korean registry and a Spanish registry. There's also interesting data that came out of Excel, which showed that those patients who had the smaller final stent area had a less good outcome. So I think, although it's not randomized trial data, it's very compelling circumstantial evidence that intravascular ultrasound is particularly useful in optimizing our results in the left main. So intravascular ultrasound has a very important role in left main, but what we found is when we talked to a number of senior operators, there was a lack of standardization of an approach. Now, what I'd like to see, as intervention becomes a bigger part of the treatment algorithm for left main, we need to be sure that we translate the results of the trials into our clinical practice. And the way I think we can do that is to be sure we're getting the sort of results that we got in the clinical trials within our clinical practice. So this algorithm guides you in the assessment of the patient with regard to how you use IVUS, which vessels you should be IVUSing, what the treatment criteria are to move you from a one stent to a two stent strategy, and guides you about what target areas you should be achieving once you've finished or think you've finished the procedure. If you don't fit those or meet those target criteria, the algorithm will guide you as to how you should optimize that result further in order to do the best job for your patient and hopefully achieve a long-term result which is going to be robust for the patient in the long term.
Innovation and you. Philips.